this is going to be, I think, relevant for a lot of you in the audience based on getting to know some of you and what your practice is like. So we're going to talk a little bit about what it means for effective communication with people perhaps outside your practice, okay? So I'm going to go over and map the context of survivorship and outline some of the key players as it relates to coordinating care for your patients, and then talk about survivorship care plans and what those involve. All right, audience response. So according to the American College of Surgeons and their Commission on Cancer, patients choosing radical prostatectomy to treat their cancer should be provided care plans prior to surgery, within a year of diagnosis, after they receive their pathology report, after confirmation of undetectable PSA or completion of adjuvant radiation, or 6 months after surgery. Prior to surgery. Wow, okay. Let's go to the next one. Which of the following best approximates the incidence of impotence after radical prostatectomy? 15, 25, 50, 75, or 90%? Okay, so it's kind of spread out. Most people choosing either 50 or 75%. All right, great. So, you know, for those of you in the audience, I just put this up here to show how relevant you are nationwide. If you add up, if you're looking at the survivors in the US, right, there's 12 million Americans living with cancer, 1 in 10 households with a member diagnosed in the past 5 years. But look at these numbers. 1 in 5 are prostate cancer, another 7% are also genitourinary. So that's over a quarter of all cancers among survivors in the country, right? So that's big for urology. So Fitzhugh Mullen, physician, okay, was diagnosed, treated for cancer, and essentially wrote what amounted to an essay in the New England Journal back in the mid-'80s. And this kind of leads us into survivorship. He said the challenge in overcoming cancer is not only to find therapies that will prevent or arrest the disease quickly, but to map the middle ground of survivorship and to minimize both its medical and social hazards. So, led to a description of what patients' rights consist of in this situation. Well, to have a record and understand what they're getting as far as treatment, to know what's going to happen next in terms of follow-up, what late effects are possible, and then to know what is life going to be like. What do they have to look for? How do they maintain their personal health? What kinds of issues, both medically, but then non-medical, psychosocial, financial, and what resources are available to them. So about 12 years ago, the Institute of Medicine released this report called From Cancer Patient to Cancer Survivor, Lost in Transition, okay, because of poorly fragmented care. And they identified specific needs for these patients who complete treatment, and they were saying that there's a lack of awareness of what these patients need, and that care is just poor in terms of our communication with everyone else involved. So they called for written summaries that should include the expected recovery, the schedule of recommended follow-up screenings, what kind of information should tip patients off to recurrence of disease, and what kind of resources are available for them. So who are the key players in this process? Well, the primary care provider remains essential, okay, but I still view the cancer care provider, which may be many of you in the audience, as the quarterback in this process. Plus or minus a survivorship navigator, and we'll talk about that a little bit more as we go on, and plus or minus mid-levels or advanced practice professionals. So this is a list of components that I came up with as it relates to survivorship, because even though I'm not the cancer care provider at Wake, I still direct the prostate cancer survivorship program. And you might think, well, I'm only really representing a small portion of this in terms of, you know, anatomic restoration. And you will see people that treat ED and incontinence and say they run a survivorship clinic. But that's only one small part of it. To really treat these patients effectively, you have to consider the whole gamut of what's required, right? I will tell you that if you identify someone within a field of psychology who's, you know, a good provider for your patients, protect them, because as soon as you tell other people about them, they get so busy, you can't get anyone else in to see them. So they're worth their weight in gold. So when people say, who do you use? I say, oh, I don't have anybody. But that's not entirely true. But I'm just telling you to identify these resources. And you might say, well, that's going to take some time. I don't know where these resources exist. Well, I'll show you something in the course of this presentation that'll do that work for you. So something we don't talk about with our patients a lot is their financial challenges, right? It may involve the money they shell out for prescriptions, over-the-counter drugs, supplies, loss of income. And so these discussions only take place perhaps a third of the time. So oncology social workers, if you have those at your institution, and financial counselors can find resources to often be inadequate for these patients. There are actually financial counselors specific to patients with cancer. So what about physical changes in these survivors? Well, one study estimated that about 1.5% of all men over the age of 45 to be cancer survivors with current adverse physical symptoms. So the majority have had symptoms at some point, and about 75% currently have symptoms. So in terms of impotence, right, 76% of radical prostatectomy patients with impotence, 64% after radiation and hormone therapy. And again, those numbers will fluctuate based on what you read, and I understand that. 70% will have incontinence at any time, 28% currently, and then of course we're all aware of these other physical changes. What about cognition? Well, it can be from the disease, it can be from the treatment, it can be from complications, it could be from other comorbidities, or it could just be associated with the stress of having a diagnosis of cancer. So both chemotherapy and androgen deprivation have been associated with decreases in cognition and visuospatial skills. So one of the things that I see in practice is how, I don't want to say detrimental, but let's say how tragic it can be for some patients when they're no longer able to drive. If you take away a patient's ability to drive, it really sends them on a downward spiral. Okay, so it's important to be aware of this. So the American College of Surgeons Commission on Cancer met in 2012 and developed standards, and these were to be implemented by 2015, so 2 years ago. These involved a navigation process, screening for psychosocial distress, and care plans. So the navigation process is supposed to be evaluated every 3 years to look at the what you have available in your community. Barriers to care, gaps in resources. You don't necessarily need to employ a navigator, but you need to have the process. And you can see some of the barriers there for patients in your community. So there's a number of tools to screen for psychosocial distress, and they don't specify that you need to use any one in particular. But in 2007, there was another report from the Institute of Medicine that called for these at a pivotal medical visit. So patients that are identified as having distress need follow-up. And if you have oncology staff, there are NCI-funded training programs available. Now, this is in red, so I'll read it to you, but it's apos-society.org. So this is the American Psychosocial Oncology Society, right? And so I find that a lot of people are aware that this society, are unaware that this society even exists, but it's a valuable website. So they can actually identify resources based on your zip code. So what about care plans? Well, these consist of a treatment summary and a follow-up plan, and they're now recommended for all cancer patients by the Institute of Medicine. So going back to what I said before, we need better communication among all team members. And it's now part of a mandate. So if you're operating at a cancer center that's accredited by the American College of Surgeons, this is now a standard. And so these care plans need to be provided to patients with stage 1, 2, or 3 cancers, treated with curative intent for their initial occurrence, or those people that have completed active therapy. So who delivers these? Does it have to be the physician? No. It can be any one of the providers listed here. If you have a credentialed navigator, you can do it, but it can't be a lay navigator. And again, this is defined in their standards as published in 2016. So it can be printed or it can be electronic, incorporated into your medical record, but it's got to contain input from the principal cancer care provider and team, as well as input from other providers. So if you're coordinating across multiple institutions, that can be a challenge, right? And you want to overcome the poor communication we've seen in the past. So in all cases, these groups should work together to provide the information necessary for completing the care plan containing all required elements. So what about timing? They are to be given within a year of diagnosis, or 18 months if they're on long-term hormone therapy, and no later than 6 months after completing adjuvant therapy. Providing it by mail, electronically, or through a portal without discussion does not meet the standard. So they established deadlines. So by the end of this year, again, linked to accreditation, these need to be provided to at least 50% of your cancer patients. And programs are required to track and report the number provided. So ASCO met in 2012 to develop a strategy. And they found that these care plans were not going to be done if it was too onerous for providers. And so they assembled a group of what they felt to be stakeholders to determine how best to do this. So the treatment plan, so there's two key documents, right? There's a treatment plan when the patient initiates treatment, and then there's the survivorship plan, which includes a summary of what you've received and your plan for follow-up. So in the summary of your treatment or treatment summary, these were the components that they felt to be important, right? So you specifically explain the diagnosis, the stage, what they've received and when. Ongoing toxicity or adverse events of all treatment received are also included, as well as information on the likelihood of recovery. Perhaps relevant to a lot of the talks at this meeting, genetic or hereditary risk factors were all also listed. So what about the follow-up plan? Again, you need information on the cancer care provider, adjuvant therapy, the schedule in a formatted table, and general statements regarding their follow-up with a regular doctor and reporting of symptoms, a list of resources, and then general statements as it relates to their overall health. So what are the barriers? Well, the biggest one that people perceive almost immediately is time, right? Time and resources. So the work group found it took about 10 minutes, right, once they trained a nurse to do this. Another concern is inadequate reimbursement, and then challenges in coordinating care and incomplete penetrance of electronic health records. So ASCO came up with a list of guidelines as it relates to prostate cancer survivorship, endorsing the American College Guidelines from 2014 with some minor modifications and qualifying statements. They have 39 recommendations, 4 were actually on sexual dysfunction, 3 on intimacy. And again, what about implementation? So think time, think resources. Only 20% of oncologists report consistently providing care plans, and only 13% of primary care doctors report consistently receiving them. However, if these primary care docs receive these care plans, they were 9 times more likely to discuss survivorship with survivors. And the more often they get them, the more confident they are managing late-term consequences. So, in terms of timing, cancer care providers in one study felt 3 to 6 months after treatment was optimal. The existence of your program, however, should be mentioned to patients at the time of diagnosis. Patients like to know that they're in good hands. They like to know that they have a team looking out for them. But you need to make the process easy. So, the most widely endorsed strategy is a template with pre-specified fields. And now there are resources to make this easier. So I presented this at LUGPA at the meeting in Denver, I believe it was last year. So these are now produced by Boston Scientific, okay? These are unbranded, and they will customize these to your practice, right? They'll change the graphics, they'll essentially put the provider or, your group of providers here, right? And then they have everything there for you. And they even have local representatives. So if you say, they come to you and they say, well, who's your go-to for, pelvic floor physical therapy, or financial counseling for patients, or this, that, and the other, to fill out all these pre-specified fields. If you say, well, these are my people, and they'll put their name so it's printed, and it's already in the template. If you say, I don't have resources for these certain things, they will find them for you, okay? So I developed this with industry, and it's been rolled out nationally. And it's been a positive piece for encouraging better communication among team members. So what about anatomic restoration? As I mentioned, this is just a small component, but as a reconstructive urologist, this is a big part of what I do. And they're important elements. We already spoke about the sexual and urinary health needs of patients yesterday. But there's an opportunity for cancer care providers to form an effective team with prosthetic urologists. So the more volume seen by a prosthetic urologist, the better their outcomes. Same thing with cancer physicians, right? The more you do, the better you get. But it's important for people who do the same type of work that I do to recognize that the cancer care provider needs to remain the quarterback, right? Because that's still the main focus of their overall situation, right? Prioritizing cancer care. And so I think a lot of it boils down to better communication skills. There are some barriers, right, to involving another urologist sometimes in the care of a patient. And we found that through better education, I would say better use of certain words, that you can kind of overcome some of those barriers effectively to the betterment of patient care. So another thing that I've been asked about is we taught a course at the AUA previously on shared medical appointments. So when we think about the time involved in filling out these care plans, it seems ideally suited to a shared appointment, and those are billable, right? They can't just be a lecture as per the guidelines, but those are billable, and you have to give the patients the option to ask their questions directly and so forth. I also talked about how just doing pre-op shim scores can be helpful, not only for the survivorship part of it, but also for reimbursement. So let's go back to our questions, okay? So going back to what the ACS has established, okay, patients choosing radical prostatectomy should be provided plans when? Prior to surgery, within a year of diagnosis, after they get their path report, after confirmation of undetectable PSA or completion of adjuvant radiation, if planned, or 6 months after surgery. Great, so most of you got the correct answer. Let's go to the next one. Which of the following best approximates the incidence of impotence after radical prostatectomy? And D is correct. So, in conclusion, survivorship requires a multifaceted, team-based approach. Care plans are now an essential and mandated part of cancer survivorship. So better communication should translate into better cancer care, compliance from patients, quality of life, and satisfaction scores, which are important to all of us. And resources exist now to make this process easier. Thank you.